Again, my name is Alexa Tinsley. If you don't know me, I am Director of Programs for Jett Foundation. Again, thank you so much for joining us today on our webinar on regional palliative care in the South. We are very grateful to Rikki Hooper from Four Seasons Hospice for helping us make this webinar possible and sharing her knowledge and expertise with us. We understand that, care in different areas regionally can be different. So being able to have this for, that South region is really important to us. So we want to thank her for being here. To share a little bit about Rikki, she's a strong believer in quality care at end of life and advocates for her patients and families to achieve their goals. She's a certified advanced hospice and palliative care nurse and provides care for patients in all settings, including pediatric and adult. So she has a wide range of expertise. She also serves on the AAHPM Task Force for Quality, and outside of work, she has volunteered at free clinics in Henderson County and has also, fun fact, been a Girl Scout leader for 17 years. So we're very excited to have her. Before we get started, I do just want to mention a few things. If this is your first webinar, we do these throughout the years on a variety of topics. So check out our website to learn more about what we have coming up. This webinar is being recorded, so if you have to log off for any reason, lose connection, or if there's anyone that you know that wanted to be a part of this webinar but was not able to, we will have this listed on our website and our YouTube after the fact for people to watch after. We will be doing a Q&A after the presentation. So Zoom has changed a little bit, maybe not for everybody, but it has for me. So instead of 2 question boxes or 2 little chat boxes, it now has 1 question mark box down at the bottom of your screen. We do primarily use those for questions, but we try to monitor the chat. This is also being streamed to Facebook Live, so we do try to monitor any questions that come through there as well. So if you have questions throughout the webinar, please feel free to put them in there. There is also closed captioning and language translation if that is something you need. So that is also in the bottom of your screen. It says show captions, and you should be able to adjust to your own settings from there. So with that, I'm going to hop off and I will give it to Rikki to give us all of the information. Again, thank you guys so much for being here.
Thank you so much. Well, good afternoon or good morning, depending on your time zone. So we're going to talk a little bit about progressive neuromuscular conditions and palliative care. I'm mostly for children, but certainly this does transition into adulthood. And so I want to make sure that we're thinking about that and answering any questions that might come up. So I want to share just a little bit about Four Seasons. So we are an organization in Western North Carolina. We serve about 14 counties across the Western North Carolina region, and we butt up against the Tennessee line, the Georgia line, and the South Carolina line. So sometimes we do see patients that may live in one area and come to another area for care. And I've certainly taken care of children who will go down to South Carolina, to Greenville or Spartanburg for their tertiary level medical care. So this is just a pictorial, kind of representation of our region. We have 3 different kind of distinct regions, and that just really means that we have a specific team of clinicians that serve those areas. So this just gives you a little bit of a general picture. So what is palliative care? So palliative care very often can get confused with hospice care. But palliative care is a medical specialty aimed at providing care which is focused on improving the quality of life for however long that might be. It could be a few weeks, it could be days, it could be months, it could be years. And so really, we want to establish a program of care that is goal concordant. And so really providing an extra layer of care. So what does goal concordant mean? It means that we establish what the goals of treatment are, what the goals of medical care are, and then we try to advocate for that level of intervention. And that may change over time. What you want to focus on now may not be the same as you focus on in 6 months or 2 years down the road. Palliative care can look very different in different locations and through different organizations. There are some organizations that don't offer pediatric palliative care at all. There are some hospice organizations that don't offer palliative care as an adjunctive support service. There are some hospice organizations that do offer palliative care, but it really is aimed in at the population that may be not quite hospice eligible. So in that 6 months before you might get a terminal diagnosis. We have expanded our philosophy of palliative care, and we look at each individual case. And so for pediatrics especially, we may follow children for a long period of time. So as many as one patient I had for 15 years before her eventual death related to her primary diagnosis. So it really looks different. And so I encourage you, wherever you're at, to ask specific questions of that organization and kind of see what they're going to provide for you and your family. So hospice and palliative care are similar, but different. So palliative care, as I said, focuses on quality of life. Well, hospice does too. Palliative care overlays that curative focus or aggressive interventions, whereas in hospice, the focus is much more on comfort than cure or even life-prolonging measures. In palliative care, you can certainly continue to receive more aggressive interventions under the hospice care benefit. There may be some interventions that are possible if it's focused on improving quality of life and decreasing symptoms. On the palliative care side, approval for certain equipment, for certain medications has to come through insurance policies, whereas on the hospice side, that has to come from the hospice. Now, most states in the South, thankfully, do now offer what we call concurrent care for pediatric patients under hospice care. What that really means is that you can get some interventions. Your child may be able to go to the hospital and get more aggressive interventions. Children with malignancies may continue a palliative treatment focus with radiation or with even chemotherapy, and that is paid for concurrently under their insurance, their state insurance. Not all states have embraced that, and some states are more difficult to navigate actually being able to put that into practice. But it is definitely a step in the right direction for children and the care of them and support for families as well. So practically speaking, on the palliative care side, that is, your visits are billed through insurance policies. It covers medical care. It does not usually cover direct care or respite care. So under palliative care, you're not likely to get a home health aide coming or those kinds of direct services. It does not mean that your provider could not advocate for those services through insurance coverage, and that's certainly been a big part of what I've been able to do with some of our pediatric patients, is really work with the state agencies on getting patients and their families approved for nursing services, for home health aid services, for other supportive services and respite care, etc., so that they have what they need to be able to live at home. On the hospice side, that does cover nursing care. It does cover personal care with home health aides. It covers medical care. It also covers the cost of medications and equipment, depending on what the primary diagnosis might be. So what could you expect from a palliative care consult or from ongoing palliative care services? A comprehensive assessment of symptoms, a review of your medications, advanced care planning conversations, which may seem a little premature. It doesn't mean that we necessarily do that on the first visit. It means that those are conversations that we start. We may include the completion of forms like a MOST form. So in North Carolina, it's called a MOST form, Medical Orders for Scope of Treatment. In South Carolina, it's called a POST form, Provider Orders for Scope of Treatment. And I think it's very similar or almost the same in Tennessee. The forms look a little different. They may be a little different color, and the person that can complete them may also be different. And the ability to have a copy of that form be valid can also be different state by state. So it's important that we understand what the rules of the state are. We may also complete an order for, not attempting resuscitation. I don't particularly care for the term DNR, do not attempt resuscitation. I much prefer the allow natural death, an acronym which some states actually use, which seems much more appropriate. And we can complete those documents when that's indicated and a choice from the family. We collaborate a lot with other medical providers. And then we obviously are having ongoing collaboration and communication regarding medical changes. That may mean that we have to collaborate with multiple different hospital systems. I have pediatric patients who see specialists in 4 different tertiary hospital systems. And so that means that there's a lot of phone calls, there's a lot of emails, there's a lot of communication back and forth. But it's very helpful for families who are not spending, 6 or 8 hours on the phone every week just trying to connect with people. And then we obviously provide assistance in connecting with other resources. As I mentioned, in North Carolina, it's the CAP-C program, so the Community Assistance for Children, and other resources that might be available depending on the community that you live in. Who might you see? You should see a medical provider. That could be a nurse practitioner like myself. It could be a physician. It could be a physician assistant. You may also see a registered nurse. You may also see a social worker. So for our team, we have all of those members as part of our team. And we have a nurse that is pediatric certified. And so she's able to kind of really be helpful in making phone conversation, making phone connections with families and really assessing symptoms when changes happen, so that I'm not necessarily having to run all over the county at all times. So it's really helpful to have other people that you trust and that can be useful and helpful in your care of patients and families. How often might you see somebody from the palliative care team? That depends on the program, depends on the patient's needs. It could be in person, it could be virtual. Generally speaking, if there are symptoms to be managed, you're going to see somebody more frequently. We've got a couple of children that at the beginning of the time that I was seeing them every week. And then we kind of moved out to every 2 weeks and then every month. And so most children I see about every 4 to 6 weeks. Sometimes it's a little bit longer, especially if there are other disciplines that are helping to support the care of the child. I have one child that I usually see about every 3 months, but in between my visits, she's connecting with a nurse, she's connecting with a social worker, she's connecting with a music therapist who is helping her identify ways to self-regulate her emotions a little better. We can do in-person visits. We can also do virtual visits. And so those can sometimes be helpful in between in-person visits. So sometimes people may ask, when should you involve palliative care? And again, that depends. Sometimes around the time of diagnosis can be very stressful, and having palliative care involved can be helpful to support people through that time period to kind of help them figure out navigating the system, how to pull in different resources, and then things may settle out and you may not need us for a while. Sometimes people wait until symptoms start becoming noticeable or problematic, and then we're really able to focus on interventions. Sometimes it's when a family may need more support or guidance about decisions that might need to be made. When there are major functional changes or inabilities of the child, or there's some new situation that arises. Any of those occurrences or situations are appropriate to involve your palliative care team. It could be that you see them for a while and then they step back out, and then you may need them later on. And so I've got some case studies at the end of the presentation, and I'll talk a little bit about how that works or has worked for some of us. So some of the progressive neuromuscular conditions that we see or have seen, these are all conditions of patients that I've taken care of in the last decade or so. So Duchenne's muscular dystrophy, obviously, Becker's muscular dystrophy, which looks a little different, mitochondrial disorders, which cover a plethora of different clusters of symptoms, metachromatic leukodystrophy, and then Sanfilippo syndrome. Those last two tend to be a little bit more rare, but they are both conditions for children that I have taken care of in the last couple of years. And so I wanted to make sure to include them because they are definitely progressive and can have some pretty important things to kind of think about. I think the important thing to remember is that every child is different. So even if you've got, Duchenne's muscular dystrophy, just because this child has DMD doesn't mean that this child is going to have the same set of symptoms, is going to change at the same rate. Everything is different depending on the child, depending on the treatment choices, depending on other factors. There may be complicating factors such as incidental illnesses. There may also be social determinants of care, which do impact the development of conditions and other symptoms that may crop up. So with Duchenne's, some of the things that we see in different age ranges are listed here. So, in those early years, some children may develop kind of the inflammation very soon after birth, and muscle fibrosis can be seen as early as 1 year old. It's not always picked up during that time. There may be some motor delays, and maybe kind of, as speech develops, some pediatricians may pick those signs up early. Sometimes they don't get diagnosed until, almost kindergarten age. And so 5 to 7 years. And that's when we really start to see some symptoms picking up, particularly discomfort in the lower legs, that calf tightness, muscle tightness and cramping even, and children that start to kind of walk on their toes. And so as we see those things, then we start to think, oh, okay, something else is going on here. So sometimes diagnosis is made around that time. And then as time goes on, depending on some of the interventions that are chosen, there could be other things that begin to crop up. And so we encounter those and try to really address some of the choices and make decisions based on that. And so kind of really choose the path A, B, or C, depending on what the overall goals might be. So Becker's muscular dystrophy, much like Duchenne's, is an X-linked genetic condition. It does usually affect males. So in Duchenne's, we generally only ever see that in little boys. But with Becker's, you may have some females that can have some effects also. It's generally less clinically obvious. And I remember seeing an adult with Becker's muscular dystrophy several years ago, probably around 10 now, but he was one of 9 children, 5 boys and 4 girls. And 6 of the 9 children had Becker's muscular dystrophy, and they identified that it had obviously transitioned from their mother, and her brother, 2 of her brothers actually had Becker's muscular dystrophy too. They just never really were able to identify that until her children started developing it as they were getting older. Symptoms can generally start with these children between 5 and 15. But they do tend to lose ambulatory ability between the ages of 25 and 30. It's generally a very slow progression, and the cardiomyopathy can be the biggest problematic condition for these individuals, and that's what we tend to see more with women who are also have the Becker's muscular dystrophy gene. Mitochondrial disorders, as I mentioned, vary widely in presentation depending on which mitochondria or the chromosomes are affected. They do vary in presentation and can often include seizure disorders and nutritional challenges. I have one little boy that I take care of who has basically pancreatic insufficiency related to his mitochondrial disorder. And so that presents some difficulty with glycemic or glucose management, as well as nutritional effects, and his seizure disorder as well. Metachromatic leukodystrophy, these children can appear normal at birth and even up until around 2 or so. And so once they get to that phase, they may develop normally and then all of a sudden are not doing what they were doing before. So the child can be crawling or even walking, and then will start to lose the ability to do those things. So they start going backwards. And so symptoms may begin appearing as a toddler, but they also may not appear until they're 5 or 6. And so it really is difficult to sometimes pinpoint exactly what's going on. The progression rate varies. And the important factor, I think, here where palliative care can be most helpful is preparing parents and the rest of the family for changes proactively. So we're really looking at the progression rate in a proactive manner and thinking, okay, well, if they were doing this 6 months ago and they're not able to do it now, what will they not be able to do in 6 months from here? And what do we need to think about as far as nutritional support or ambulatory support, or even being able to sit up and hold a child's head, etc. So car seats, home safety aspects, etc. Sanfilippo syndrome, again, is a nutritional type syndrome where the ability to process proteins is affected. Symptoms may start as a toddler, and again, the child may seem to be developing normally, but then start to kind of backslide. And again, progression rates are widely variable. Nutrition needs can be very challenging to meet because of their inability to process proteins and other nutrients. And so finding feedings for these children can be pretty difficult. Some of the symptoms that we see associated with these progressive neuromuscular disorders: pain, trouble breathing, anxiety, not just for the child, but also for siblings and parents, sleep issues, and then behavioral challenges. And so really being able to dig in a little bit with all of these symptoms and not just think about medications that be able to manage it, but also think about supportive interventions like music therapy, like aromatherapy, like counseling, just lots of different aspects that we may be able to employ to assist in managing the symptoms and supporting family members. So I mentioned earlier on about advanced care planning. So the whole goal for these conversations can be difficult, but the purpose of the process is really to be able to help people make decisions about what types of care they would want given certain health circumstances before they occur. It includes the completion of specific documents very often, and that includes children and their wishes. So when we talk about cases, I'll talk about some children that we've been able to do that with as they were older, 14, 15, 16, really honoring their ability to have autonomy and the right to decision-making for themselves. When we have these conversations, we want to kind of introduce the concept. We want to normalize the process and normalize that conversation, and then develop some relatability. And it's not just about code status or the decision to resuscitate or not resuscitate. It really is about planning for the future care needs, future medical interventions or options. We want to focus on what quality of life is for that child, for that family, what's acceptable to them and what's not. Understanding what their value system, what their spiritual background may be, and how that might affect their decision choices. So when we have these kinds of conversations, we want to determine healthcare goals as part of caring for someone fully. To really care for them, I need to understand what it is that they want from their healthcare, what it is they don't want. What do they think they can achieve, and what may be reality may be a little bit different, and sometimes we have to have some discussion about that. But I need to understand what's important to them, understand what's acceptable, what's unacceptable, and then tailor the conversation to their specific medical condition and their specific personal situation. We don't want to rush those conversations, and we want to make sure that we're allowing time for questions. And so it's a little bit like, taking a journey across the United States. You cannot go from Miami to Alaska in a 1-hour visit. You've got to be able to go from Miami to Fort Lauderdale to Jacksonville to, you just really got to take it step by step. Sometimes a lot of these conditions can last a long time, right? Especially with something like a Becker's muscular dystrophy. So transitioning to the adult world can be a scary and challenging thing. So really understanding what that might look like, and then starting early to establish who will assume responsibility for what parts of medical care. Some pediatricians will continue to take care of a child until they're 21. Some pediatricians will cut off the line at 18. Some specialty physicians will continue into the adult space. Some will not. So we need to understand who is going to do that and who won't. And if they're not, who do we need to establish care with? We want to make sure that we're beginning collaborative conversations with those providers, letting them know what goals of medical treatment have been established, what do we still need to talk about, what might be an option and what might not be an option. We want to start working on prior approvals for insurance coverage and equipment, etc., because the approval process for children is very different than the approval process for adults in the insurance world. Then we want to make sure that we're completing any necessary legal paperwork or advance directives before the child gets to be 18. Once you get to 18, there are some specific nuances to guardianship, etc., that have to be navigated. So if you could establish all of those things for a child before they turn 18, that is much easier and involves the Department of Social Services and the legal system much less. So establishing who will make medical decisions or other decisions for a child that's not able to make their own is important to establish before they get to be 18. So let's talk a little bit about some case studies, some children that I've cared for over the years. So a number of years ago, I was asked to see triplets who had been diagnosed with Duchenne's muscular dystrophy at 3 years old. They were identical triplets, born a little early. They were premature at about 32 weeks and were obviously cared for in the NICU at the time. As they developed as toddlers, it was initially thought that their developmental delay was because they had been premature infants. They then started developing some very classic signs of Duchenne's muscular dystrophy with the toe walking, with tight calf muscles, etc., and underwent biopsies to determine their diagnosis. They did have some siblings. They had an older brother who did not have Duchenne's muscular dystrophy, and they have an older sister who obviously did not have any signs of these kinds of situations. After I started seeing them, it was determined that they had some cousins, some male cousins, who also had Duchenne's. So I first saw the boys at age 8 when they were in school. They had already lost their ability to ambulate and mostly were able to move around by crawling around in their home. They did have electric wheelchairs that they couldn't use in their home because there wasn't enough space, but they would use them to be able to get to and from school and around the school. Followed them for about 2 years. We had to make some decisions about orthopedic surgeries that had been offered for tendon release, etc. The boys were very articulate and were able to participate in some of those conversations. And then they moved, and so we didn't follow them for a while, and then they moved back to our area at around 14 or so, and at 15, when things really started to change, we were reconsulted and have now followed them for about 6 years. And so they're now all over the age of 18 and have varying rates of progression of their disease. So although they are identical triplets, and obviously genetically then all had the same genetics, they have had different rates of progression and different symptoms, and those seem to have been related a lot to their early infancy and who had more pulmonary issues in the NICU, etc., etc. So as they transitioned into adulthood, there were some difficulties in communication with their mother, who struggled a great deal in allowing them to make their own decisions about their healthcare and their healthcare interventions. One of the boys who has a very challenging respiratory situation made the decision that he did not want to use any respiratory support. He did not want to have nighttime ventilation. He does not want to have a tracheostomy. And in fact, his two brothers also have made that decision, although one of the others now uses a BiPAP at night. They have each made different decisions, although, when they were younger, they acted as one and would make decisions for the unit of all three of them together. So it's been interesting to see as they've developed their own individual personalities. They are still cognitively intact and able to make their own decisions. And so now that they are of age, they have begun to elect their own healthcare directives. And so our social worker has really been able to help support them in developing an advanced directive each, and help their mother work through the challenges of their autonomy and allowing them to make their own decisions, which she's really struggled with. She now has a younger son as well, who does not have Duchenne's muscular dystrophy. And even when her daughter had to get to 18 before she could make a decision to get genetically tested to see if she was going to be a carrier for Duchenne's, because her mom did not want to allow her to go through that as a teenager, which was also an interesting conversation. So James was another child that we cared for with Duchenne's muscular dystrophy. He was diagnosed at the age 6. In part, that was because of their socioeconomic status and not participating with ongoing healthcare as the child got a little older. We were consulted again at about age 8 when he started having some more difficulty. Now, the triplets never got steroid therapy early in their life, in part because their mom had seen their cousin use steroids, and he gained a lot of weight, developed diabetes, and that created a whole nother set of problems. And so she made a decision not to use steroids. James's parents did use steroids, and that created some challenges with his weight and his ability to be mobile, because he just couldn't manage that body weight. He had a younger brother, age 4. Unfortunately, his condition rapidly deteriorated, and after 2 years, we did transition him to hospice, really because of a worsening cardiac condition. He developed a cardiomyopathy and heart failure that was really challenging to manage. The challenge, one of the struggles that we had with James was getting testing for his younger brother, because some of the physicians that they were involved with did not feel that it was appropriate to test him if he did not yet have symptoms, but his parents wanted to be able to know earlier on so that they could make decisions about caring for him, which seemed like a valid and reasonable thing to do. So we were able to advocate for that, particularly as James got sicker and needed more support from our hospice team. Ultimately, he was able to die at home with his family with good support and good symptom management, which was what they wanted in the end. So Katie was a 7-year-old who was diagnosed with Sanfilippo syndrome at around age 4 years. She came to us for hospice care, essentially, after a prolonged hospital stay. She had developed COVID-19 and some significant respiratory distress, and required intubation and ventilation for a week. And then they had difficulty being able to get her adequate respiratory support before she was able to go home. Her parents wanted to be at home with their older daughter. They had already got private duty nursing for 16 hours daily, but there was some other pieces that we need to put in place. Respiratory support when she was sleeping, suction, feeding tubes, all of those other pieces to put together. And so we were able to support them at home for about 8 months under hospice care with the nurse going at least once a week, sometimes every day. She had a number of exacerbations during that period of time where she would become hypoxic, have a really low oxygen level, have a lot of secretions that we needed to manage. But we were able to work with the family, with the pediatrician who they trusted, having had a long-standing relationship, and then with the private duty nursing agency to be able to help make sure that all of the needs were being taken care of on an ongoing basis. One is a little child with metachromatic leukodystrophy. He was diagnosed at age 3. He has one older sibling and 2 younger siblings. He came to us very shortly after his diagnosis, so 3 months after his diagnosis. He has unfortunately had rapid progression of symptoms and functional decline. So really went from being ambulatory and eating by mouth and saying words to not being able to even sit up or hold his head. He does not speak at all. He can't hold even a sippy cup at this point. And so really starting to have conversations with his parents about nutritional support and his ability to swallow. And is it better to go ahead and get a G tube now to support his feedings before he might have an aspiration episode, and what do they want to use that tube for, and really kind of working through what their value set is and what they may be open to and what they're not open to. So that's been kind of an area to work on over several months in really understanding where their needs are. Some of the other children that we've been able to take care of, have gone through similar kinds of situations where we've really tried to think through what might be the next decision coming down the pike. And after that decision, you have to make this decision. And what are the options, the pros and cons of every intervention? And so, I really say to people, we want to really establish what might this intervention do for you, and what could it do to you or your child, whether that's Tylenol or steroids or some kind of immunotherapy or a surgical intervention. So we really want to understand what could it do for you or to you, and those may not necessarily be the same things. Questions? It's a lot of information.
Vanessa, I see you have your hand raised. If you do have a question, please go ahead and put it in the Q&A box at the bottom. But Rikki, thank you so much for putting this presentation together. And I love the examples. I think, real life examples are super important. I do want to mention one thing just for your education and the education of the community. We are learning that a lot more females are affected than previously thought with Duchenne specifically. We have not only older females that have heart issues and muscle issues, but we're finding girls who are diagnosed at 9 who are having heart issues and like implanted loop recorders at 15. So as you start seeing more of these, and I think that knowing that in the community that palliative care would be an option for those females, and whatever way that may look like for them in the future, is important. I mean, we have what we would consider manifesting carriers that are presenting the same as a boy with Duchenne at the same age as.
That's I mean, I've seen that definitely with the Becker's muscular dystrophy in my experience, my clinical experience. And it seems to be like you've got these subclinical things going on, and so then all of a sudden you get to 15 and you've got cardiomyopathy that you didn't even know you had. So
and I think that's what we're finding in females a lot too, is that they're getting cardiac MRIs and there's damage that they didn't even know existed. And I think I think the South specifically can be really difficult when it comes to late diagnoses, but also I think just in general around the country, it's getting better, but taking females seriously as a female with Duchenne. So hopefully you see more of those, or hopefully you don't.
Yeah,
But
right.
hopefully they start to be taken more seriously and get better care in the future. So
Yeah.
I do see, let's see. So there's a question about resources. Vanessa, I'm going to connect you with our social worker, Jessica, who can help you specifically with some resources for those things that you just listed.
Mm-hmm.
So if you want to shoot me an email, alexa@jetfoundation.org, I can get you connected with her. But if anybody has any other questions, please feel free to put them in the chat. I'll give everybody another minute while I check Facebook to see um, if there's anything from there. But Rikki, again, thank you so much, because I do think
You're
that
welcome.
the more information, the better, for
Yeah,
sure.
we are seeing a lot more community-based palliative care programs that are able to serve pediatric patients. They may not necessarily come out as frequently as we do in our local area. I'm actually trying, I have two patients that are moving to different states. One's going to South Carolina, one's going to Tennessee. And so proactively, I'm trying to make sure that they've got that support network, already established there. So that we don't lose any traction in essence, and they don't end up in the hospital getting stuff that they really don't want.
Yeah.
So I think it's been helpful to kind of connect in. I've, made some time or spent some time connecting with the pediatric team at the Levine Children's Hospital in Charlotte, and the clinics in Spartanburg and Greenville, and then obviously, and now Knoxville, Tennessee, just to be able to get this other little guy transitioned to the Tennessee area. So
And I think one of the other things that I took from, and I continue to take from these presentations, is like the difference between palliative care and
yeah,
hospice. And I think that up to this point, there are so many people that see them as the same, and they're
right.
really not. So thank you for actually showing the separation and how they're different. It does not look like we have any questions, but if anybody does have any questions after this presentation, please feel free to reach out to myself, Alexa@jetfoundation.org, and I will get them over to Rikki to see if we can get them answered. Thank you all so much for being here today. Rikki, again, thank you so much for your time. We
You're very
could
welcome.
not do it without you.
Yes.
So thank
Happy
you
to
to
answer
everyone.
questions. All
Yeah.
right.
So, and like I said, this is recorded. So if any questions come through, I'll be happy to send them to you as well through that forum as well.
Great. Great.
Awesome.
Awesome.
Thank you all so much.
Thanks
Have a
so
wonderful
much.
day.
You'll have a good afternoon.
Bye.